Okay, good evening, everyone. Let's go ahead and get started. Welcome to the 8th Mini Medical School of 2021. My name is Jenna Jones. I'm a first-year medical student at IU School of Medicine, and I'll be your moderator for the session tonight. As you can see, the format's a little different this year with it being held over Zoom, but we're happy to have you here with us tonight. And real quick, just in case you have missed a few sessions, if you want to go back and look at those, you can find them at indstate.edu/minimed. And so no worries if you've missed anything, you can hop on that and find it there. I want to take a second to thank our sponsors. And so I'd like to thank Hamilton Center, Indiana State University, Indiana University School of Medicine, Terre Haute, Lugar Center for Rural Health, Minority Health Coalition of Vigo County, Terre Haute Regional Hospital, Tribune Star, Union Health, Via Media, West Central Indiana AHEC, and WTHI TV. Next, I would like to explain the logistics for tonight's event. The Zoom webinar platform will allow us to feature our local panelists. All other attendees should be muted during this presentation, and we encourage you to submit your questions during the presentation using the Q&A button located at the bottom of your screen. Your questions will be answered by our panelist following a brief intermission after his presentation. Tonight's topic will focus on treating joint pain. The panelist for tonight is Dr. Jeremiah Palmer. As an orthopedic surgeon at the Union Medical Group Bone and Joint Center, Dr. Palmer presents regularly on joint pain problems and solutions. He will be sharing much of his expertise tonight on this topic. Dr. Palmer works to identify individual patient goals and develop treatment plans to reach those goals, whether that means a pain-free joint or everyday activities, or return to the playing field. He works to select the best treatment for each orthopedic condition in order to return patients to an active lifestyle. His specialty is in sports medicine and arthroscopy, as well as general orthopedic conditions for adults and children. A native Hoosier, born and raised in Indianapolis, Dr. Palmer graduated from DePaul University in Greencastle, Indiana, and obtained his medical degree from Case Western Reserve University in Cleveland, Ohio. Through his extensive training and work experience, Dr. Palmer has had the opportunity to care for and treat athletes at every level of competition, from recreational athletes to professionals. He helped take care of college athletes at DePaul University, University of Maryland, and Rice University. In Houston, he was also part of the medical team caring for the Houston Astros, Houston Rockets, Houston Texans, and the NASA Astronaut Corps at Johnson Space Center. Currently, he is the team physician for Rose-Hulman Institute of Technology, St. Mary of the Woods College, and Northview High School. So without further ado, Dr. Palmer, please take it away.
Thank you, Jenna. And thank you to everyone for joining us this evening. This is my first time giving a presentation via Zoom, so please excuse if there's any technical difficulties, but hopefully we'll get through it pretty smoothly. As Jenna mentioned, tonight we're going to be talking about joint pain, and I'm an orthopedic surgeon at the Bone and Joint Clinic here at Union Hospital in Terre Haute. So tonight we're going to go through kind of a typical med school curriculum. So for those of you who are not familiar, med school typically is 4 years in length, and there's a pretty standard kind of curriculum that most schools will follow. The first year we typically go over anatomy and physiology. So for that we'll talk about the structure and function of joints so we can know what the normal structure and function is. Then in the second year, typically students will learn more about the pathology or the disease. So we'll talk about the joint disease and the actual causes of joint pain. In the third year, students will go into clerkships. These are rotations in different specialties where we actually work with patients and start taking all the knowledge that we've accumulated in the first couple of years and applying it to actual clinical problems. So there we'll talk about how do we actually treat the joint pain. And then finally, in the fourth year, we do advanced clerkships. These are more specialized rotations. And so for that this evening, we'll talk about joint replacement surgery in particular. So joint pain in general is obviously a very large topic. We have a kind of a limited amount of time here tonight. So I'll try to focus on some topics that most people will have some experience with or typically have questions about. But if you have any other specific questions, feel free to put them into the chat and we'll try to get all the questions answered by the end of tonight's talk. So first, and Jenna's kind of already covered a little bit about this, but just to give you a little bit of my background so you can understand where I've been and kind of how my experience and education has shaped the way that I take care of people. So as you mentioned, I'm from Indianapolis originally. I went to DePaul University for undergraduate, went to Case Western Reserve in Cleveland for med school, and then traveled out to the East Coast to Baltimore at University of Maryland Medical Center for my residency, and then made a loop back towards the middle of the country down to Houston, where I was at Houston Methodist Hospital for a year doing specialized training in arthroscopy and sports medicine. And then finally made my way back, almost all the way back to home, but just a short trip down the road to here in Terre Haute. So along the way, as Jenna mentioned, I've been able to take care of athletes at all levels and all competitions, both from high school to Division III college to Division I college, and all the way up to professional athletes down in Houston, as well as getting the unique opportunity to take care of the astronauts down at the Johnson Space Center. So it's given me a wide range of experiences with a lot of different types of athletes. And it's also helped shape the way I take care of everyday people too, because most of the people I take care of are not athletes. While I was down in Texas, my wife and I picked up this little souvenir. And since then, he's grown up a little bit and has picked up a couple little buddies beneath him too. So we're happy to be here now, helping take care of all the athletes in Wabash Valley, the area high schools, and Rose-Hulman. So as mentioned, we'll start today with kind of the normal anatomy and physiology of joints. So we'll talk about the structure and function so we can understand how they work in a normal setting. So when we look at the typical anatomy, so first we'll just define the joint. So a really simple definition of a joint is really any connection between two bones in the skeletal system. So this can be any two bones at all, but there are certain bones and joints that we're more interested in. So when we look at them specifically, we'll talk about different types of joints. So we can classify joints by the degree of movement, whether they're completely immovable all the way to being completely freely movable. And we can also look at them by tissue structure. So by the tissues that actually make up the joints. And these are typically the tissues that are actually between the two bones. So just to look at a few examples, one type, if we look at different types of tissue structures, are the fibrous joints. So one specific example of this is an immovable joint, and those are the bones that form our skull. So these are the skull sutures. These fuse together early in life, and once they're fused, there's really no movement at all between them. Syndesmosis is another type of fibrous joint, and this one is slightly movable. So here on the left, we can see an example of the two bones of the lower leg, the tibia and the fibula. And the fibrous joint that runs between them is called a syndesmosis. So this is actually a ligament that runs the entire length of the leg and provides stability between these two bones. And there are times when this ligament can get injured. So in the image here in the middle, we can see a picture where the ankle is actually dislocating. And that's because of an injury to that syndesmosis. And then on the right, once it's been fixed and stabilized and put in proper alignment. Another type of joint, when we look at the different tissue types, are cartilaginous joints. So one specific type of these are called symphyses. So these are, again, slightly movable joints, and they're formed by two bones that are separated by a special type of cartilage called fibrocartilage. So some specific examples of this are in the spine, between the vertebral bodies or the bones of the spine. There's something called the intervertebral disc. So most people have heard of a herniated disc. That's the actual cartilage structure that's between those bones. And then the same kind of structure is in your pelvis, between the two halves of the pelvis and the front of the pelvis. There's something called the pubic symphysis. And again, this is a fibrocartilage disc that sits between the bones that allows for some motion, but not quite as much as some of the other joints that most people are familiar with. And finally, we'll come to kind of the most important types of joints, the ones that we take care of the most often, and these are synovial joints. So these are joints that are essentially freely movable within some constraints. And these joints are formed by two bones that are surrounded by a fibrous capsule that's actually filled with fluid. So we'll look a little bit closer at the structure of these joints here. So again, we have two bones. On the ends of the bones, we have a special type of tissue called cartilage, and specifically we're talking about articular cartilage here, which means cartilage of a joint. And then surrounded by that is the actual capsule. So it's a fibrous capsule, and within that is contained joint fluid, or what we call synovial fluid. So that helps to actually lubricate and protect the joint, and we'll talk more about that function in just a bit. But this is kind of the basic structure of synovial joints, which are the joints that, again, we end up taking care of the most of. So when we look at synovial joints in particular, there are different types of joints. So if there are any carpenters in the audience today, you'll know that when you're taking two pieces of wood and trying to put them together, there are innumerable ways that you can do this. But the way that you do it typically depends on the function of the structure that you're finally building. So the same thing with our bodies. When our bodies are put together, different joints have different functions, and so they're put together in different ways. So when we look at the different types of synovial joints, one of the most common that people are most familiar with is a hinge joint. So these are the structures, the joints of your elbow and your knees. Those are two examples of a hinge joint. These provide motion typically in one plane of motion, so bending and extending those joints. In actuality, there's some increased complexity to it than that, but that's kind of the most simple way to look at it. Another type of joint is the ball and socket joint. So these are the joints of your hip and your shoulder. So these are formed in a way that creates more degrees of motion and more mobility of those joints to allow for different types of functions. And then finally, there's several other different categories that we could look at. These are typically the smaller joints of the body when we're talking about joints in the hand, the feet, the neck, and the wrist. But these, again, are all formed in a certain way to serve the function of that body part. So, and then we can look at each type of those joints, and we can see even differences among the different individual joints themselves. So if we look at just ball and socket joints, if we look at the hip and the shoulder, the hip joint, pictured here in the center, is made up of the ball, which is the top of the thigh bone or the femur, and the socket, which is a socket within the pelvis. So, and the hip is a load-bearing joint, meaning we walk on our lower extremities. So this has to bear the load of our body weight. And so this joint is designed to maximize that joint surface by having a big, deep socket that can articulate or join together with the thigh bone, with the ball of the thigh bone. Now we can contrast that to the joint that makes up your shoulder, which is also a ball and socket joint. But here we're looking at a much more shallow socket. So here, this is pictured on the right. The socket is actually made up as the shoulder blade or the scapula, and then the ball in this case is the upper arm bone or the humerus. And here we have a very shallow socket, and that allows us a much greater degree of range of motion of the shoulder. So our shoulders have much more range of motion and flexibility than our hips, and that allows us to perform the functions that we need to with our upper extremities that we don't need to with our lower extremities. When we look at the other structures that surround a synovial joint, there's a few other things that are important in helping maintain these functions and actually getting them to function. So we talked about the bone, we talked about the cartilage, and we talked about that joint capsule. And then finally, we have ligaments, which help connect bone to bone, and tendons, which help connect muscle to bone. So those ligaments stabilize the joint, and they maintain the limits of the range of motion. And then the tendons actually connect the muscle to the bone, which allows us to actually move. So here we're looking at just an example of the knee joint with all the other structures involved in it. And so again, and I apologize, this is mislabeled here. If we look at the one that's labeled ligament, this is actually a tendon. So this is connecting the hamstring muscles, which are in the back of the thigh, down to the fibular head, which is down just below the knee joint. So that's an example of a tendon connecting muscle to bone. And then right next to it, we can see an example of a ligament. So this is the ligament that connects the outer part of the knee, a bone to a bone. And so that helps stabilize that joint and maintain the joint as it moves. So those are kind of, again, just the basic structures of a joint and the things that help make it move and help it accomplish the functions. Now, when we look at the different parts, one of the most important parts is that cartilage layer that we mentioned. So that we call articular cartilage or hyaline cartilage. And this is one of the most important parts of any synovial joint. This is actually what makes it function and allows it to continue functioning. And this is a lot of times what is going wrong when there's a problem with the joint or when there's pain with the joint. So the cartilage is the smooth white surface on the end of the bone. So if you've ever had a chicken bone, that smooth white surface, they have cartilage just like we do. And that's the way that the ends of our bones look. So here we're looking directly at the end of the thigh bone. So this is a part of a knee joint. Now that smooth surface also provides protection to the end of the bone. And most of that smooth white surface is actually made up of what we call extracellular matrix, which means it's substances that are not actually cells, it's substances that the cells produce and maintain. So, and in the particular case of articular cartilage, most of that is actually water. So just like the rest of our bodies, a good portion of this is made up of just water. And in fact, when you look at the wet weight of cartilage, about 80% of it is just water. So, but that water is very important because it allows load bearing and it allows for distribution of the forces in the joint so that our bones don't actually experience all that load. So with the adequate water content in cartilage, fluid pressurization alone can bear nearly 90% of that load. Also in that extracellular matrix, there are proteins called collagens. Those help maintain the structure of that matrix. And then other substances called proteoglycans, which basically help attract all that water and maintain all the water content in the cartilage. And then that subsequently provides that compressive strength. Only about 5% of the cartilage is actually made up of cells. Those cells are called chondrocytes. So those cells help actually produce the matrix. So they produce those proteins, they help organize it, and they help maintain it. And those cells also respond to mechanical and chemical stimuli. So just the simple act of standing up and putting on our weight, those chondrocytes or cartilage cells will actually respond to that and can adapt and make changes to the cartilage as needed. Now here we're looking on the bottom half of our screen here, a microscopic view of some hyaline cartilage. And so again, the majority of what we see here, this light purple, is actually that extracellular matrix. So again, that's made up of water and proteins, and that's most of the structure. The small purple dots that we see are the actual cartilage cells or the chondrocytes. And so it's important to kind of note here how isolated they are in that matrix. So, and within the articular cartilage, there's actually no blood vessels or nerves. So these cells get all their nutrients from the matrix around it and from the fluid in the joint, and then some nutrients that actually come up through from the bone. So, but they're very isolated and they have very limited ability to replicate. And that's important because it's very hard to repair this cartilage tissue. So there's no access for the cells, for any other cells to come in and repair that tissue. So when damage or injury occurs, it unfortunately can start a downward spiral for our articular cartilage. So here we're just going to kind of review the main points that we need to know about the synovial joint anatomy. So on the left, we see the gross anatomy again with two bones with articular cartilage along the end, that's signified by the blue layer here, and then a joint capsule that surrounds and encloses and maintains that joint fluid in the space there. If we zoom in and look at just a microscopic view again here, we'll see again this cartilage layer, which is signified by the blue, signified by the blue here with those cartilage cells that are embedded in that matrix. And then down below, we see healthy normal bone and the bones and the cells of the bone, which are called osteocytes. Those help maintain that bone down below. So we're going to return to this picture in a little bit when we talk about what can go wrong with this and how it can cause pain. So that's our first year. So now we're going to move on to our second year of med school, and we're going to talk more about pathology or disease of joints. So we'll talk about things that can actually cause pain and how that happens. So there's lots and lots of the different causes of joint pain. So we're going to focus tonight on really just a few. So the most kind of obvious and one of the most common is simply trauma or injury to the joint. So trauma and injury can be acute, meaning sudden, or it can be chronic, where it occurs over time, such as with overuse injuries. So injuries to the joints can include contusions or bruises, sprains or strains, which just means stretched or torn ligaments or tendons, fractures, which just means a broken bone, or instability of the joint. So times when the joint dislocates or comes out of place. Sometimes these are very obvious. So on the picture on the left here, we've got that's called a tibial plateau fracture. So this is a break of the upper end of the shin bone. And there's really no mistaking this. There's lots of different fragments here. And typically for a break like this, basically what we try to do is put it back together. So as much as we'd like to think we're doing specialized things here, a lot of orthopedics is glorified carpentry. And so really the goal here is just to put everything back together and hold it in place. On the right, we see a dislocation. So this is a shoulder joint. So again, we talked about that's a ball and socket joint. And here we can see that the ball, the humeral head, is not lined up with the socket. So this is a dislocation. This is obviously painful, and that needs to be replaced back in its position to help alleviate that pain. Some injuries are not so obvious. So this is a single image from an MRI of a knee. So, and here we're looking at the upper portion of it here is the femur or the thigh bone. And then the lower portion is the tibia or the shin bone. And on this particular MRI, anything that is white signifies fluid. So here we can actually see two bright spots of fluid that are actually contained in the bone. So these are actually bruises in the bone themselves. And this has occurred because this person has a tear of the ligament inside the knee called the anterior cruciate ligament. So that allows for abnormal motion between these two bones, and they actually bump into each other and cause the bruising here that we can see. And so we can tell that by physical exam, we can tell that by the imaging, but that's another cause of joint pain. The other main cause that we worry about and that we deal with most of the time is inflammation in the joint. So this is anytime you see a word with the ending itis, that means inflammation, and this is what we deal with a lot of in orthopedics. So inflammation itself is simply the immune system's response to any injury or tissue damage or infection. So now the process itself is extremely complex. So it starts with some sort of stimulant or irritant, and that sets off a cascade of events that occur in the body through cell signaling, and certain cells get turned on and certain cells get turned off, and it allows this huge cascade of events that initially leads to a couple of different things. When we see that in a person, we see that as what we call the pillars of inflammation. So these are heat, redness, swelling, pain, and eventually loss of function. So these are all just part of inflammation. And again, this is just the immune system's response to injury. It's our body's attempt to try to heal any kind of injury, tissue damage, or infection. So within that, we can talk about different types of inflammation. So again, the most common that we deal with in orthopedics is osteoarthritis. So this is known as degenerative arthritis, or arthritis that occurs as a result of wear and tear of the joints. So this typically occurs over time. Another type of arthritis is called inflammatory arthritis. One example of this is rheumatoid arthritis. So this is where the body's immune system is actually inappropriately reacting to our own cells. So in rheumatoid arthritis, the immune system is actually attacking the cells of the joint, causing the pain and swelling, and actually leading to destruction of the joint. Tendinitis just means inflammation of the tendon, and then infection can obviously also cause inflammation, and that we treat with sometimes with a surgery, but also with typically antibiotics. So again, we'll focus here on osteoarthritis, as this is one of the most common reasons for joint pain, and we'll return back to our normal anatomy that we learned in our first year. So here we've got the synovial joint, and we have our normal, what we call an osteochondral unit, which just means the bone and the cartilage of that joint. So in osteoarthritis, in the initial period of osteoarthritis, we see some damage to the cartilage surface itself. So we see some breaking up of the actual matrix surface. And initially that actually causes increases in the water content and swelling of the actual cartilage itself. Down below, we also see increased fluid content, and so the bone has more fluid in it, and it responds as well. And then the cells of the cartilage and the cells of the bone actually respond and help set off that inflammatory cascade. So they send out all those signals that the immune system picks up on and actually starts the immune process or the inflammatory process. As that progresses, we see different changes that happen typically. So one is that the number of substances that help retain the water in the cartilage actually decreases. So we start seeing the water content decrease. And along with that, because that water is important in absorbing the force across the joint, we see increased force on the bone below. The bone cells then respond to that by increasing the thickness of the bone and changing the actual architecture of the bone itself. Finally, down in the bottom illustration here, we see the kind of final phases of osteoarthritis, which is where the matrix continues to degrade and break down. And then the bone continues to react with formation of what are called osteophytes or bone spurs. And then bone cysts as well, which is just a fluid-filled sac where the bone is left a void, basically. And then in our late stages of osteoarthritis, we see kind of the final result, which is that the cells of both the cartilage and the bone actually begin to die. And with that, they're no longer able to maintain those structures. So the matrix of the cartilage continues to break down. Sometimes it will break down completely and actually leave bare bone behind. The cells in the bone also die, and they are not able to remodel the bone as well. And then you see actually introduction of increased blood supply and then actual nerve supply into this area as well. And so then you get more swelling and more pain. And so the cycle continues. And this leads to swelling, stiffness, and the pain that we feel in our joints when this occurs. So that's a very, very brief overview of some of the causes of joint pain and the way that those diseases progress. So now that we have some of our vocabulary and we have a little bit of the basic knowledge, now we can move into the third year of med school, or we're going to go into the clerkships, and we're going to actually learn how to take care of actual patients. So we'll start off with a patient presentation here. So we'll start with a 58-year-old woman who comes in with left knee pain after she's had a twisting injury to her knee. She's had several years of kind of occasional pain and some stiffness, but really tolerable, nothing that made her come in and seek any treatment. But suddenly it's worse after this injury. She's been having some popping and some catching and some locking in her knee. She's tried to modify her activities. She's tried to avoid the things that bother it. She's been doing a little home exercise program. She Googled some exercises and has been doing some stretches and some strengthening work, but it hasn't really helped very much. And she's been taking some anti-inflammatories. So she's been taking ibuprofen, which helps kind of take the edge off of her pain, but isn't helping relieve it completely. Otherwise, she's very healthy. She has no other medical problems that she knows of. And when we examine her in clinic, she has a little bit of pain when we palpate over the inner part of her knee. And she has a small effusion, which just means that she has a little bit of extra fluid in the knee than what we would expect. Here's a look at her x-rays. So this is a look at her left knee. And on the left image here, we're looking from the front. So here we've got the thigh bone and the shin bone. And really the most important thing on these x-rays is going to be the space in between the two bones. So this is where the cartilage lives. We can't see cartilage on an x-ray, but we can look at this and see how much space there is between those bones. If we see a healthy space there, then we can assume that there's some level of healthy cartilage there as well. So at least on this x-ray, this looks okay. However, if we take a little bit of a different view and we have her actually stand up and put weight on this knee, we can see it changes quite a bit. So now when we look at her left knee, which is actually on the right of the screen here, we can see that that space that was once there is actually gone. So this is osteoarthritis. So, and this is what we call bone-on-bone arthritis, meaning that all that cartilage is diseased and worn away, and now the bone is actually rubbing against itself. So we can also see along the edges of the bone here, we can see some very small, again, osteophytes. These are bone spurs. Those are just a sign of arthritis. And if we look and kind of compare the two sides, we can actually see that the bone here on her left knee, it's actually a little bit thicker here, just underneath the cartilage layer. So that's where that bone is actually thickened and reacted to the extra stress that's been applied to it. Here's just one more view to show that and to show how it's different from her other knee. Now, there's lots of different treatment options for arthritis, but we're going to kind of jump ahead for her and show you the final result for her. So she went through this course of conservative treatment that we had talked about, and eventually she had some persistent symptoms that really weren't tolerable for her and that were limiting her activities. And so the ultimate treatment for her was actually a knee replacement surgery. So we'll talk more about this in just a moment, but that was the conclusion of her story. So, but we'll come back now and talk a little bit more about osteoarthritis. Again, this is one of the most common things that we see in orthopedics, one of the most common problems that we take care of, and something that almost everyone experiences at some point in their life. So osteoarthritis is again, a gradual thinning of the cartilage that cushions and protects the ends of the bones. So we call it's wear and tear that happens over time. Now, sometimes it can progress faster, but generally it takes several years for this to progress, and sometimes an injury can stimulate to move along faster. Here we're looking at a shoulder joint. So again, we have a ball and socket joint. The ball here is the arm bone, the socket is the shoulder blade. And here again, we can see there's really no space in between those two bones. Again, we see large bone spurs down here. Those are, again, it's just a sign of arthritis. So that's how osteoarthritis looks in the shoulder joint. Symptoms of arthritis, the most common kind of symptoms. Well, as we mentioned, this is usually a gradual onset, and it usually gets progressively worse. Sometimes it may very, very slowly get worse over many years, and sometimes it may suddenly get worse. Typically, there's stiffness that involves moving those, that makes moving those joints difficult. And that pain and stiffness is sometimes worse in the morning or after prolonged inactivity. So when people have been sitting for a long time, or when they first get up in the morning, they have a lot of the pain and stiffness. As they move more, it begins to improve. And then typically after really prolonged activity, then it starts to get worse again. Oftentimes people will experience popping or catching or clicking in the joint. And oftentimes we'll have patients that will complain about how the symptoms that they have change with the weather. So we don't know exactly why this occurs, but something with the barometric pressure and the weather changes tends to cause more joint pain. In terms of treatment, we have lots and lots of different options for how to treat arthritis. And some of these have better results than others, and some have different indications as opposed to others. And so really it's a matter of making sure that we tailor these to each individual person. So first, when we kind of sort through these, first I'm just going to go ahead and pull out joint replacement surgery. So that, when we think about treatments for arthritis, is kind of the ultimate treatment for this. So we'll talk about it more in just a bit, but we actually replace the joint surfaces themselves with metal and plastic, and so we actually eliminate the arthritis. But that takes a surgery, and there's some risk involved, and so certainly we try to avoid that if at all possible. So there's lots of options that we have short of a surgery. And so we'll kind of sort those into one category, which is things that are recommended for almost everyone. Those are things like physical therapy and home exercise programs, modifying your activities, and using anti-inflammatories. So these are all things that we generally recommend them for everyone because there's very little risk of something going bad with these, depending on other medical conditions. But most people can tolerate these treatments well. And the risk of something bad happening is very low, and the potential benefit is very large. So that's why these are recommended for almost everyone. On the other side, we have a lot of treatments that have really limited evidence. So things that have not been proven by science, things that may work for some people but not for others. So in this category, we do include things like corticosteroid injections, which we offer to almost everyone with arthritis. But The problem with those is that we don't know who they're actually going to work for. So again, they're low risk. The potential benefit's pretty large, but we have limited evidence and don't know exactly who the best patients are to receive those. There are other types of injections as well. One is called viscose supplementation or gel injections. Some people refer to these as rooster cone injections. That's an attempt to try to lubricate the joint and also decrease the inflammation. And then another type of injection is something called platelet-rich plasma, or PRP, which you may have heard of. More recently, things like stem cell injections have gained more traction. Both of those have pretty limited evidence, and as such, they're not used very extensively right now. But certainly, those are promising avenues for the future in terms of how we take care of joint pain. Things like an arthroscopic cleanup surgery. So when we say clean up arthritis, there's really no way to clean that up, because the actual problem here is that the cartilage is missing. So there's very limited things that we can do through an arthroscope, which is where we insert a camera into the joint to actually fix those problems. So that's not usually indicated for most people with arthritis. And then controlling the pain with things like acetaminophen or Tylenol and narcotic pain medication. We know the dangers of opioid medications, and we certainly try to avoid them as much as possible, given the potential for abuse and the fact that they just don't provide a lasting relief. So our bodies adapt to them, and they require more and more increasing doses to get the same relief. So that's not a great long-term solution. So how do we decide between all these factors? Well, it really depends on a number of factors. So one is the severity of symptoms. How bad is it? So for the majority of people with arthritic symptoms, it's tolerable, and they can treat it with things over the counter like anti-inflammatories or Tylenol. Obviously, as they progress and get worse, then our treatment options will change. The patient's age and other health conditions certainly play a big component in this. So someone who has a lot of other medical problems, heart problems, lung problems, they may not even have surgery as an option because it may not be safe to perform a surgery. So then we have to look at all those other non-surgical options. And then we look at patient expectations. So what is that specific patient expecting to get from the treatment? So some people may not have relatively large expectations. So some people may just want to feel good on a day-to-day basis and be able to walk around and go to the grocery store and be pain-free doing that. While as others may have higher expectations and may want to return to sports or running or other activities. And so we try to take that all into account as we're picking between these different options. And then finally, we talk about the risks and the benefits of each treatment option itself. So we kind of briefly covered some of those, but the treatments that have the greatest benefit don't always have the greatest risk, and sometimes things are risky beyond what we're willing to accept. So when we look at those conservative treatment options, again, we can talk about modifying activities. So that simply means just avoiding things that bother it. So and sometimes that's reasonable. So sometimes we'll have patients who are really active and want to keep exercising, but if we can just modify those exercises or change them so that they don't exacerbate their symptoms, then that's a reasonable treatment options. Medications can sometimes be helpful. Again, we talked about over-the-counter medications such as acetaminophen, which is a pain reliever, Tylenol, and anti-inflammatories, so things like ibuprofen or naproxen. Those are really aimed at, one, relieving the symptoms, and then also decreasing the actual process of inflammation. So trying to actually fix the problem and resolve that issue. Injections, as we mentioned, so things like steroid injections, which again are aimed at decreasing the inflammation. And then again, things like PRP or platelet-rich plasma. And then more recently, things like stem cell injections. Really, all of those types of treatments are aimed at trying to change the environment inside the joint. So if we can decrease that inflammation, we can decrease the pain that it's experiencing, and really the ultimate goal would be to develop something that we could inject that could actually decrease the progression of disease or possibly even reverse it, but we're certainly not there at that point yet. Physical therapy is the last thing that I'm lifting here, but it's actually one of the most important things. So physical therapy can help immensely in treating osteoarthritis and all kinds of joint pain by helping restore that function. So therapists are especially trained in helping restore the range of motion and restoring the strength and again, finding ways to help modify activities so that we can restore function as well as possible. And even if it's not something that prevents a surgery, it's certainly going to be important in recovering from surgery as well. So unfortunately, there are times, though, when all of these things fail and when symptoms are still intolerable and we have to look at different options. And so that's when we move into our 4th year, and we're going to go into our advanced clerkships, and we're going to focus tonight on joint replacement surgery. So joint replacement is where we actually remove the damaged cartilage and bone, and we replace it with metal and plastic. And our goal here is to restore that joint's function and restore it as normal as possible to alleviate the pain and to get back to functioning as normal as possible. So the most common types of joint replacements, the ones we see the most often, one is a knee replacement surgery. So here we're actually replacing the bone and cartilage on the end of the thigh bone and the top of the shin bone, and replacing that with metal on the end of each bone, and then a plastic insert in between. Hip replacement surgery, again, very common. Here we're taking the damaged ball and socket joint, and we're putting in a metal socket and a metal ball, and then replacing and putting a plastic liner in between those two. So again, our goal here is to replace all that damaged bone and cartilage, eliminate the things that are causing the pain, and restore that function as close to normal as possible. And then finally, one of the other most common ones is shoulder replacement surgery. This is becoming more and more common. Here again, we're just replacing those parts. So we have damaged ball of the arm bone and the damaged socket of the shoulder blade, and we replace that with a metal ball. And in this case, we typically replace it with a plastic socket. For shoulder replacement surgery, there's actually 2 different types. So one is what we call an anatomic total shoulder. That's where we replace the ball with a metal ball and the socket with a plastic socket. And then another type is called actually a reverse total shoulder replacement. So this is where we actually swap those pieces. We put a metal ball on the socket side, and we put the plastic socket on the arm bone side. This we use in special situations where people don't have a well-functioning rotator cuff. And this changes the mechanics of the shoulder just a little bit to help maximize the strength of the muscles that are remaining. So how do we specifically do that? Well, we'll look at here at an example of a knee replacement, just kind of the basic steps of how we actually go through that surgery. So first we make an incision and we expose the actual knee joint itself. Here we have an illustration showing the damaged cartilage and bone. And so we remove all that cartilage. We have special instruments that we use to make cuts in the bone. So we actually cut off the end of the thigh bone and the top of the shin bone. And our special instruments help guide those cuts to make them perfectly in the shape that we need to have them in. And then down here, we can see that once we've done that, we can implant these new pieces on. So it's a metal piece on the end of the thigh bone here, and then a metal tray on the top of the shin bone. And on that tray, we can insert a little plastic piece that serves as a spacer in between those 2 metal pieces. Oftentimes, we'll also replace the cartilage on the backside of the kneecap. So we do that with a small plastic button that sits on the back of the kneecap. And then we sew all the pieces back together, and we have a well-functioning joint. So those are the really basic steps of a knee replacement, and hip and shoulder replacements are performed in similar ways. Obviously, the parts are a little bit different. And I'll give you a few links here at the end of this talk that you can get some more information on how those surgeries are actually performed. And if you want, you can even find videos so you can see the actual surgeries being performed. So the recovery from joint replacement is different for each joint and different for each patient. In general, the initial period is just the recovery from the actual trauma of surgery. So that takes several weeks typically because there's a lot of swelling and inflammation just from the surgery itself. Eventually, we start gradual use of that new joint with certain restrictions. So for hip and knee replacements, we typically let patients walk immediately. For a shoulder replacement, you're typically in a sling for some time while things are healing. And then we start home exercises and physical therapy, which again helps to restore the motion and strength of that joint. And our goal, again, is to restore it back to a normal functioning joint. So, so here are a couple of those resources that I was mentioning to you. One is our hospital website, myunionhealth.org. If you go to that and you search for orthopedics, or if you go through the services and find the orthopedics portion of that website, you can find information on joint replacements and some of the other services that we offer. And you can find some links to some videos of other presentations that we've done talking about these different problems. And then the second website here is called orthoinfo.org. This is a website that is put on by our National Academy of Orthopedic Surgeons. This has lots and lots of information and also some videos and other links that you can find more information on, and more detailed information as well, again, since we have such limited time tonight. So that is our run through 4 years of medical school talking about joint pain. So now you can put on your scrubs and go out and take care of some patients. So thank you for being here with us tonight, and I'd be happy to answer any questions that we have.
Thank you, Dr. Palmer. I think at this time, we'll take a quick 5-minute intermission. During the break, a pop-up window will appear on your screen to collect some basic audience information. Please complete this poll by making your selections and clicking submit. We will also have our Q&A session after the intermission. Just a reminder that many medical school attendees may type questions throughout the session using the Q&A button at the bottom of the screen. We will address them after the intermission. One last thing, there will also be a survey with some questions we ask you to answer after the session tonight. I'll remind you of this survey after the Q&A concludes. So we'll hop on here at about 7:22. So we're going to resume the session and go ahead and jump into the Q&A. Attendees, please feel free to continue submitting questions if more come to mind. The first question, Dr. Palmer, is glucosamine and chondroitin were listed. How is their use helpful?
Yeah, so glucosamine and chondroitin are, you can think of them as joint supplements. So those are substances that are already part of the joint. And so the idea is that if there is damage to the joint, that those levels have decreased. And so if we can take that as a pill, we can supplement that. So there's again, that's in the category of limited evidence. So there's really only a few studies that have showed any real significant benefit to using those medications. And those were the most kind of quoted one is actually sponsored by one of the companies that makes it. So what I typically advise patients is that, one, there's little to no danger in using those. So we know that they're not harmful or hurtful at all. The risk of taking them is very low. And so if that's one of the only options that we have, then it may be worthwhile to take those and see if it provides any benefit. But I certainly wouldn't recommend continuing to take it unless you really see a specific benefit to it. But that's kind of the idea behind those is they actually are trying to supplement the joint. The hard part of that is that you're taking a pill, those substances have to go through your digestive system, get absorbed into your body, and then somehow make their way to the actual joint, which it doesn't really work that way. Our bodies break down things and then rebuild them on their own. So theoretically, we like to think that they're beneficial, but oftentimes they're not. So.
Thank you for that. The second question is, what do you recommend for a patient with fibromyalgia to help alleviate pain?
Yeah, so that's an excellent question. And that's one thing that we were not able to cover tonight because of, again, kind of a limited time constraint here. But fibromyalgia is an almost completely different category by itself in terms of one of the causes of pain. And so that's where pain is extending even beyond the joints and into the muscles and structures around it. So that's why myalgia means muscle pain. The fibros are referring to the fibrous tissues. So typically those conditions are treated by a rheumatologist, and they're typically treated with medications. So there's no structural problem necessarily. And so they're treated with medications to help decrease inflammation and decrease the actual sensation of the pain itself. And And so as an orthopedic surgeon, I'm not the best one to answer that question in terms of specific medications to use, but that's what a rheumatologist would take care of.
The next question, arthritis runs in my family. Is there anything that could be recommended to reverse it?
Yeah, so that's an excellent question too. So we see this a lot. We see, and certainly we know that there is a genetic component to arthritis. With everything else being equal, we still see that there's some genetic component. And so some people are going to develop arthritis, without injury, without overuse. And so in terms of ways to reverse it, there's really no way to turn it back. So once that damage occurs, again, because of the structure of the cartilage and the limited ability of our cartilage cells to repair things, there's no way to actually turn that back. There are other procedures that we can use to help repair damaged cartilage. So short of doing a complete joint replacement, we can sometimes actually replace or fix certain small parts of cartilage. But there's no way to actually turn back and get that normal cartilage to come again. And so obviously that's kind of a point of future research. In terms of preventing arthritis from actually occurring in the first place, there are things we can do. So one, we know that repetitive activities and repetitive loading of the joint are things that are going to lead to arthritis, especially if you're prone to it to begin with. So when you are exercising or in activities, you want to make sure that one, you're using good form in your exercises. You want to make sure that you're avoiding any repetitive high impact activities if possible, especially if you're prone to arthritis or if you've already developed it. We know that weight loss is extremely important. So our joints see, just our knee joints alone can see 5 times our body weight just doing normal everyday activities. So certainly excess weight is going to cause excess stress on those joints. And so for people who have a genetic predisposition to developing arthritis, we have to look at it from all those factors and try to modify each factor as much as we can.
Thank you, Dr. Palmer. The next question, Humira is being prescribed for my mother. It doesn't seem to be helping and the side effects are so dangerous. Is there anything else that she can be prescribed?
Yeah, so that's kind of a specific question, and it's going to depend on a lot of different factors. So Humira is a special type of antibody drug that is used typically, again, for inflammatory arthritis. There certainly are other options now, and as our technology has gotten better and better, we've got new drugs that are similar to that that are coming out every year. So again, a rheumatologist or an internal medicine doctor is going to be the best person to sort through which medications are going to be best for treating her specific condition.
Next question is, I have no trouble walking or working out. When I'm on my knees in the garden, I'm having pain, even with knee pads. What would you suggest?
Yeah, so part of that depends on what's actually causing the pain that you're having. So kneeling down on your knees specifically, oftentimes we can see people with arthritis that affects just the area of the joint underneath the kneecap. And then we can also see inflammation of the tissues that are actually just underneath the skin, but not even inside the joint. So if there's swelling or inflammation there, knee pads are a great place to start. So I'm glad that you've tried that already, because certainly just the pressure and the stress of being on the knee itself is going to cause damage to those tissues and cause inflammation. So the next step is trying all those other things we talked about for inflammation, which is using things like anti-inflammatories, icing to get the swelling down, and again, as much as possible, modifying those activities. There are some times where we can get inflammation there in those tissues that does not respond to those. And so sometimes we actually have to perform a surgery to remove some of those tissues that are inflamed. So that's when you have something called bursitis, which is just inflammation of a specific structure underneath the skin there. It's not very common that it comes to that, So usually those other strategies will help take control of that pain.
Thank you again. Next question. When dealing with collegiate athletes that have cubital tunnel syndrome, what is the first recommendation for a treatment option that you would try?
Yeah, so cubital tunnel syndrome is a condition where the nerve that supplies some of the sensation and motor function to the hand is getting pinched at the elbow. So actually on kind of the inner aspect of the elbow. And that can occur for a number of reasons. It's typically an overuse type of condition and will come on slowly and then progressively worsen. And it occurs because the nerve, as it travels through that specific anatomic region, is coming through a very small area, and that's why it's called a tunnel. So the nerve gets irritated, and then you get these symptoms. So for really either collegiate athletes or any patient, the first ways to try to take care of that are, one is by decreasing the stress on that nerve. So one really common treatment option is to actually use splints that keep the arms straight in a straight position overnight. That helps take stress off of that nerve, and when used, for a period of time, that can actually sometimes be enough to help relieve that condition as well. Sometimes steroid injections can be helpful for that, and then as it progresses and worsens, the ultimate treatment for that condition is actually a surgery where we release that tunnel and try to create some more space for that nerve so it's not getting compressed.
The next question is, should I see a specialist since I know there is a history? Any recommendations for where I should go?
Okay, I'm guessing that this is related to the question about arthritis running in the family. And so in terms of, do you need to see a specialist because of a family history of arthritis? Not necessarily. So unless you're experiencing symptoms yourself, if you are experiencing symptoms, the first place you can stop is always your primary care doctor, but we have specialists that cover every joint here at Union at the Bone and Joint Center. So if you're having pain in a specific joint, we can certainly take care of any of that here.
The next question is, can scoliosis cause osteoarthritis?
Yeah, so scoliosis is a condition where there's a curvature of the spine. And that can be caused from a number of different ways. So one, and probably the most common, and the most common that people probably think of when they say scoliosis is the kind that has an onset as an adolescent. So as children are growing, occasionally they'll develop this curvature in their spine. Other ways that it can occur are actually over time. So people can develop scoliosis as they get older, and actually arthritis can lead to scoliosis. Scoliosis by itself can lead to arthritis over the long term, but it's not as likely to work in that direction. So they've done studies where they look at people with scoliosis and the incidence of back pain is usually about the same. So, but it actually can work in the opposite direction, where arthritis can lead to breaking down of the joints of the spine and actually lead to that curvature.
Thank you, Dr. Palmer. The next question is, my knees pop often when I stand up from sitting or lying down. Is that a concern with my joints, or is that normal?
Yeah, so we hear this a lot, and in most cases, if the popping is not painful, and if it's limited to just certain positions, then there's not really a concern for that. So the reason that our joints actually pop when people pop their knuckles or when they pop from movement, it's actually from the motion of that joint that you or the fluid that you have inside the joint. So as that fluid moves from one area to another, occasionally it will pop and cause that sound. So it's not necessarily a bad thing, especially if it's not associated with any pain. So if that's the only concern, then certainly that can be normal. If it's associated with pain, then that could be a sign of a different problem.
Thank you, Dr. Palmer. I think that's all the questions we have right now in the Q&A box. I'd like to give everyone a quick second to drop anything in or ask Dr. Palmer another question before we head out. It doesn't look like anything is popping up. Feel free to pop in while I'm talking here if a question does come up, but that will conclude tonight's mini medical school. Thank you once again to Dr. Palmer for taking time to share with us, and thank you to all of our attendees for joining us and sharing your questions. We hope that you'll join us again. Mini Medical School will be every Tuesday for the remainder of April from 6:30 to roughly 8:30 via Zoom, with the next topic focusing on infant home safety. As a reminder, if you've missed a session, a recording is posted on the website under the date for the talk you missed, so you can find that there. When the meeting ends, a survey will pop up with some basic questions. Your feedback is anonymous and will be used in the planning of future mini medical school sessions. Thank you, and I hope you have a restful night.
Thanks, Jenna.
Yep. Thank you, Dr. Palmer.
Good night. Good night, everyone.